Good afternoon. I hope this debate will be as lively as the first one. So we will start. I'll introduce our surgical colleague, Alex Bernhardt from Hamburg.
Thank you for the introduction. And first of all, I have to say, I'm not sure if this is really a debate, recovery or heart transplantation. So from my personal view, it is not a debate. But I'm really lucky that I can stand here, and thank the organizers to be presenter here. But I think we will have a lot of agreement on this topic. So first of all, my first disclosure is I'm a believer in recovery. So this is I also have to say this. Here are my financial disclosures. And when we talk about bridging to heart transplantation, so first of all, we would like to have a safe bridge. So is this bridging? This is supposed to be one of the most dangerous bridges in, I think, Pakistan. And the question is also, where do we want to bridge? Is it safe, and where is our goal? So this is a bridge. It's a little bit older. This is during a bike ride I did on Sunday morning, and this is a very solid bridge, and we have a clear goal here. So bridge to transplant by short-term devices. This is a bit not older publication, but it's a publication based on the ICE-HLT data, so worldwide data on heart transplantation and post-transplant outcomes. And as we know that the majority of transplants has been performed in the US, and this is the data come from times where we did not have the Impeller 5.5, for example, and before the heart allocation process changed in the US. But what we've seen, and you see the upper curve, this is continuous flow devices, so we only see patients bridged by mechanical devices, and ECMO patients have the lowest outcomes. But I already said that the allocation process in the US changed in favor of patients on short-term devices, and impeller devices, for example, are in status 2, from the best of my knowledge, being not a US physician. And after this change, the outcomes have been compared here in this very recent study published in the Journal of Heart and Lung Transplantation. What has been seen is here that after the change, the death on waiting list went down, transplant rate has been increased. There are probably more reasons for that, maybe more available organs as well, and waitlist removal went down, and this also and the post-transplant outcome has been the same. So waitlist mortality went down, transplant rate was increased, and the sickest patients did not die on the waiting list, but have been treated well by heart transplantation, and there are comparable outcomes then. But this is US, coming from Europe, and coming especially from Germany with a poor donation rate. The situation is different, and we have to consider this when talking about bridging by short-term device, or bridging specifically with impeller devices to heart transplantation, that there are different allocation, or countries with allocation and different allocation proceedings here. And the organ donation rate is much lower in Germany, and also the median donor age, it's much higher in Germany or in Europe compared to US, as you can depict it here. And this results in a growing waiting list, and also growing waitlist mortality. So patients have a relevant and much longer waiting time in Germany and Europe. And we have colleagues here, for example, from Japan. It's even worse in Japan, for example. So the question here is, gold standard heart transplantation, it's a bit like gambling. The heart transplantation, the solution for heart failure is like winning in the lottery, the solution for poverty. So the question is again, and I don't want to annoy you by talking about allocation policies. But it's important here when we talk about realistic bridging and the alternatives, bridging by impeller device to heart transplantation. So this is the actual criteria for high urgent listing in Germany. So Germany has two urgencies. It's T status, transplantable, and high urgent status. And you have three options. One is hyperperfusion syndrome, so without any devices, being in cardiac index below 2 liters a minute a square meter under inotropic support. You have that complications, and you have the exceptional cases, and one of that are patients on short-term devices, but clear guidance who can be listed here is not given in the German heart allocation policy. So far, we are working on that. So there are, for example, I discussed it with Nia, and he will comment on that hopefully later on heart transplantation in the US, for example. But there are large series coming from the US on heart transplantation after impeller devices. So we have to present our case reports, and are very proud to do so, because at the very end we are only collecting case series but not full manuscript on this topic. So this has been presented last year by Constanze Volkmann, and the next case is presented here in the poster presentation. And it can be successfully done, but in very exceptional cases in Germany. And the question is, and I will go more into detail in a second on this, urgency. How urgent do we have to react? How long do we have to bridge our patient? How urgent is this patient? And what's the best treatment strategy and an overall treatment strategy with the best outcome for our patient? Here are some thoughts from a German or European, also surgical perspective. So what is the anticipated waiting time if you want to bridge patients with an impeller device to heart transplantation? What do we do once we have complications during our waiting time on the impeller device? Not only related to the impeller, and we know that the impeller 5.5 has a low adverse event rate, but also other complications associated with patients on short-term device or waiting on an ICU, infections, for example. Do we tend to, with anticipated longer waiting times, do we accept rather marginal organs for these patients? And when is the right time to escalate to a durable device if we do not find a suitable donor organ for these patients? We discuss in Germany, and I'm really happy to discuss also the US perspective. Do we list patients when they first time decompensated for heart failure? Or is this patient, because we don't have much time to evaluate this patient, also psychosocial aspects in these patients, which are very important. So do we implant maybe better an LVAD, or maybe, if possible, wean this patient, and we will hear more in a second from Jane about this topic. Is the underlying heart pathology important here if we wait for recovery or go for heart replacement therapy in these patients? And there's also the option to wean patients from impeller device. First, look if recovery is stable, and maybe list this patient with a hyperperfusion syndrome if needed, with a small amount of idotropes, or implant another impeller device to bridge these patients to heart transplantation. So this is, here's a really excellent example summarizing all these different aspects which are important, also considering different allocation policies and different countries and the different options we have in these patients. And what is very important is that we cannot compare all the patients. Oh, unfortunately, they use the audio here. We can't compare patients and systems between countries, so we have to define our own and individual best treatment strategy for our patients. Thank you very much.
Yeah, Alex, thank you very much, and join us. And we are continuing with the second part of the debate. This time to target for recovery. It's presented by Jen Wilcox from Northwestern.
Thank you so much. And I'd like to thank Alex for bringing his A game to the Barbie versus Ken debate. So I'm the only one that can make that joke, though. So, all right. So let's go over some ground rules, general debate rules. When preparing for this, I sought advice from my surgeon. This is Dr. Duckton Fan from Northwestern, who gave typical surgical advice. Jane, just be strong, just be confident. I call that the strong and wrong approach, but it does get the job done. I'd like to thank Meridian for her words of wisdom from a prior debate. If you can't convince them, just confuse them. And finally, it is important to Google your opponent just as much as it is to prepare with medical literature. Alex, this is the only picture I have of you.
Oh.
You can relax. And finally, I'd like to thank Jerry for just having the better argument. You can collect your payment at the end of this debate. All right, so we wouldn't be here today without the knowledge, the wherewithal that heart failure with improved ejection fraction, remission, recovery, whatever we want to call it, it exists, and it's being acknowledged in the guidelines. This is from the universal definition that was brought forth now a couple of years ago, where heart failure with improved ejection fraction now is in the guidelines, as well as management strategies. This is defined by a patient who has a prior EF less than 40%, achieves an EF greater than 40% with that absolute delta of 10%. So not just a difference in who's in the echo lab, but truly reduction in LV volume, along with improvement in myocardial function as measured by ejection fraction. This is from our consensus document now that's several years old, but when we think about the retrospectoscope, it's easy to identify someone who has responded, who's had reverse remodeling, but what are those predictors at the outset of reverse remodeling? These are a few clinical parameters, genetic parameters, as well as imaging, but you see here non-ischemic etiology, shorter duration of heart failure, things that make sense to us, the gestalt. Some genetic factors, patients with Lamin cardiomyopathy are not going to improve. Patients with Titin cardiomyopathy may improve. And there's work from that from the group in London. So what about echo factors or imaging factors? The lack of fibrosis on cardiac MRI, relative preservation of myocardial mechanics or contractility as measured by global longitudinal strain, as well as others. And finally, a sort of a less sick biomarker profile. Historically, though, when we talked about recovery was something that existed either in Utah or maybe in Chicago, Germany, places where we were just talking about explanting durable LVADs. And you can see here, this is an example of my patient here who had an HVAD implanted, a young patient with a Titin cardiomyopathy, and after a year of GDMT was successfully able to be explanted. But we need to think beyond, right, of the sort of the durable VAD. What about temporary unloading as a bridge to recovery, as opposed to going right to heart transplant? And this is data from Emma Burks and Restage from now 3 years ago. And what I draw your attention to here is that nearly everyone achieved an myocardial recovery and the ability to be explanted. With excellent survival at 36 months post-implant. One patient actually, had a non-cardiac death in this study. The point here is that GDMT, and Kanika made this point, GDMT in this study did not include the ARNI compound. It did not include SGLT2 inhibitors, and that was just 3 years ago. Right? And we all know about, drug and device development and how quickly things are moving. And so I would argue here that this strategy is probably sooner, it's closer to us in terms of temporary unloading with GDMT as opposed to long-term durable LVAD unloading with high-dose GDMT, and that's changing. Some work here, there's a mechanistic link. When we look at SGLT2 inhibitors, there's actually direct effect on myocardial metabolism, where we see that there's an increase in free fatty acids, ketone and branch chain amino acid oxidation, and directly increasing myocardial ATP production. what we see here, this is a subgroup analysis from the EMPA heart study. These are patients who had abnormal cardiac mechanics as measured by global longitudinal strain, and after a short period of time, less than 1 month, had resolution of their global longitudinal strain, and after six months of therapy had normalization of global longitudinal strain. And so I think with GDMT and adding unloading, the future really is, to sound cliche, the future is really now. So let's go over a couple of cases on what might be a good example for unloading as a bridge to recovery as opposed to a bridge to transplant. What about this is a case of 36-year-old female with peripartum cardiomyopathy. You can see her vital signs here. She's tachycardic at 120, PA pressures 48/22. Her index is 1.4. This has been going on some time. Her end diastolic dimension is nearly 7 centimeters and her EF is 23%. Pro-recovery argument would be, this is a young patient, this is new onset heart failure, she's never seen GDMT. The pro-transplant, Alex may say, yeah, but she's young, she has a poor hemodynamic profile, and she could very well experience complications as she's awaiting recovery. The elephant in the room, which Alex addressed, is the allocation system. We are not rewarded for doing the right thing. We should do the right thing by our patients, and that's really the compass, our true north, what guides us. But we're really rewarded, as a system, really by listing this patient for transplant. And so we'll go over what happens to her in a minute. What about this case? This is a case that I had in June when I was on service. 57-year-old came in with a STEMI. You can see his angiogram here, and cardiogenic shock, developed pulmonary edema. He was hypotensive post his PCI, lactates going up, started on pressors in the cath lab. They placed a CP, and it was subsequently upgraded to a 5.5 based on hemodynamics, as well as some hemolysis immediately post-procedure. He went on to, of course, develop AKI on CVVH. EF is 10%. His troponins were skyrocketed. This achieved a good result, but the transplant committee discussion really was, is he going to experience a complication? Should we be listing him concomitantly for transplant? Do we do the workup now? Do we target recovery? And these are discussions that go on in your rooms all the time that you're having these discussions. And so what we really want to get, I think this is historically what we think about in cardiogenic shock. It's this one-way arrow, right? Where we start here with a hemodynamic problem, then there's this time in cardiogenic shock, and the longer you're in cardiogenic shock, then it becomes a hemometabolic problem. And the therapy needs to be multi-organ support. Nowhere in here is really the myocardium. When we think about actual myocardial recovery and remission, improved EF, whatever that is, I think remission is a venerable goal. We're not targeting, supernormal EFs and no GDMT. That's ridiculous. We're targeting explant GDMT and kicking the can down the road until, that and really saving that patient from a durable VAD or a transplant. And so moving that upstream for hormonal support in the face of LV unloading with short-term device therapy. And so the value of trajectory, I talk to my fellows, my residents, anyone I can talk to about this putting points on a timeline. What's going on with your patient? What's going on with the hemodynamics? Making sure that you're mitigating the risk for those short-term complications, limb ischemia, things like that, as you're working up the patient potentially for transplant, but really doing the right thing and targeting recovery in the meantime. I think the other, to switch gears a bit, the other sort of elephant in the room is it's easy to throw in a device. As the non-interventionalist, I can say that. I say, hey, put in that CP for me, put in that 5.5, and Duck, as a good partner, says, whatever you want, Jane. But the tricky part can be the now what. So what are we going to do now? How are we going to wean this patient? And that's where it takes a company of the committed, right, all of us together to come up with best practices, how to wean appropriately, and what are our next steps. And so we do know this is clear. If you wean support too quickly, you have increased cell death from sudden increase in wall stress. And so that acute reloading after LV unloading is not what we're targeting. We're targeting a gradual wean. And there are two published algorithms to do that. I think this is the references didn't show up here, sorry about that. But this is the TIDE algorithm on the left, where we're using transthoracic echo under full Impella unloading, then doing a pump rate reduction according to patient hemodynamics, dobutamine stress echo, and then exercise hand grip. Raise your hand if you're using this. It's tough to do clinically. I think in our practice, we're really doing the first two with that the rate reduction in a stepwise algorithm according to hemodynamics. And on the right is Jerry Estep's group proposal for assessing clinical and hemodynamic stability prior to removing your device. In this case, it would be the Impella. So a native cardiac index of greater than 2.2, that central venous pressure less than 12. I think targeting a wedge pressure based on less than 18. We saw data from the ESCAPE trial where if you have a wedge pressure greater than 17, your risk for rehospitalization or death is high. And then finally, not having the patient on high dose or at least moderate dose of vasoactive agents. Nowhere in here, there's an EF greater than 25%, but EF does not equal cardiac output. And so I really like Kanika's data that she reviewed. The EF really didn't change much at the time of pre-implantation versus post-implantation. But what you're able to do is stabilize the hemodynamics, get rid of the hemometabolic problem, introduce GDMT, and that puts you on the road to recovery. So clearly some centers are doing this right? There are centers that have patients with Impella devices for a duration of support that's greater than 7 to 14 days or greater than 14 days. This is data from the experience from Smart Assist, where nearly 30% of patients are on support for longer than 2 weeks. What happens with these patients? You can see here the survival and recovery by indications. So someone with acute MI shock, these are patients that we should be targeting recovery, right? Because we can see that recovered nearly 70% of those patients who survived to explant, and recovery here is defined as explant of the device, not a certain EF, but hemodynamic and clinical stability where the device was then removed. Post-cardiotomy shock, clearly this is 94% of patients who are surviving are getting this removed. But if you look here, a third of patients with long-term cardiomyopathy are actually able to have the device removed and stabilized. And so when we think about which patients deserve a trial of recovery, this is sort of an easy slide, all of them. Everybody gets a shot at recovery. You can send 2 trains out at the same time. You can think about, would this patient benefit from heart transplant? Would this patient benefit from durable VAD? Or can we think about a bridge to recovery, simply those 3 strategies? And then you can switch your trains, right? We all do this on a daily basis. Is this someone that really wants to target recovery and we're gonna do short-term unloading to a durable VAD? And then, down the road, look towards explant. There are lots of different strategies here, and you need to engage your patient in your thinking process as well. These are the Wilcox top 6 for recovery targets. This is clinically, I think, who we think about patients who are going to have a high likelihood of achieving remission after LV unloading. No prior exposure to GDMT, recent onset heart failure, clearly the peripartum cardiomyopathy, abnormalities in myocardial energetics like thyrotoxicosis or tachy-mediated cardiomyopathies, in addition to Titin-related cardiomyopathies, are patients that we've been able to successfully unload and achieve myocardial recovery. So I thank you for your time, and I'm happy to take questions, and thanks, Alex, for being a good sport.
Thank you, Jane and Alex, and we appreciate you taking the tougher position there, Alex, because we know everyone in this room here is here for recovery. And I like what you said, Jane, I've long said that every heart is recoverable until proven otherwise. So I like your slide that said everyone should have that opportunity. So we have a couple minutes for comments on this and thoughts and questions. Bill?
Mark, I just have a question for Jane. In the past, there seemed to us from the outside of the heart failure world a exuberant enthusiasm for using balloon pumps, but it was primarily because apparently in the U.S. that sort of increases your listing for heart, or did in the past, for heart transplants. So I love what you said about doing the right thing, and sometimes you're penalized for it. So now with the new DRG coding for the 5.5 surgical implant, is there going to be an exuberant enthusiasm for putting that device in so that you can get a higher reimbursement? Just wonder if you comment on that.
Is this on? Perfect. So, as always, Bill, great insight. I think that the short answer is probably yes. I think the bigger elephant in the room is the allocation system. And so I think we just need to put that aside and have the patient in front of you and always doing the right thing. And I think we, in general, sort of do that. The problem is when we get a little eager and list the patient at the same time, it's hard for us to do nothing. I think as cardiologists, as surgeons, as maybe not pulmonologists, I don't know. But, just be sometimes doing nothing and waiting for time is the right thing, but it can be difficult to sort of do that because it feels like you're waiting for a complication. But I think as more centers get more experience, if your patients are ambulating, that also makes a big difference. You don't have a patient saying, "Hey, I'm on my back, and when are we done here?" Then I think you can get some buy-in. You also need buy-in from your hospital or your health system, right? This could be a longer length of stay than a typical transplant. But with the DRG coding like you're talking about, I think that may offset some of those discussions. Nir, you have to go.
So I want to emphasize a point because we are now doing a nice discussion in a nice room in Amsterdam, but the real life is very different. And this is what Alex tried to tell us, and you're saying to us. Everybody agree, Mark, what you said. Everybody deserves the chance to have recovery. But Dan and I published with Veli last year, how is it really look in the United States since the allocation changed? And we took, if you talk about people in status 1, meaning people on ECMO, in the past, 1.7% of them actually went off the list because they recovered. Right now, is 0.1%. Yeah. So this status 1, we don't even give them a chance to go to Impella 5.5 and to recover them. We don't. What happened to the status 2? The same. From 4.something% of people that were delisted because they recovered their heart, we went down to 1.6%. Meaning we can discuss and we can believe, but actually the people that decide on the new allocation system in the United States are the people that take away the chance of recovery. And the reason is that in reality, as you said, there is a lot of competing things. You explain a patient and you said to him, let's wait, let's see what direction you're going. If for God's sake something bad happened, you're getting an LVAD. And after that, we'll see if you recover on the LVAD, if you didn't that. And then he said, but if I'm going to an LVAD in the new allocation system, I'm 6'5" height, I will never get a transplant in the United States. And he's right. And actually, this is a dilemma that we have right now. And we eventually, it was a 42-year-old acute MI patient, and we said, we think you better wait a little bit before, and you really want to be listed. So the patient actually start to be educated on the risks that they are taking, and it's a little bit like Russian roulette because of it, what you decide to do. So it's not about medicine, it's actually about politics. That's what happened here.
Yes.
Jane, I think you brought up a very good point about it's sometimes easy to do a VAD transplant. I always say that it's easy to do a VAD transplant or let people die. It's the in-between where it becomes struggle on the decision-making. My question is, I struggle more with the ischemic disease on the burden of scar versus how much is viable versus not. And as one incentive we talked about is allocation system, but I feel the other disincentive of pushing for recovery and explant is a little bit of unknown on harming the patient. We had a recent case where a guy did great, was on the floor, and then just arrested and died after a high-risk PCI. So some of these implications of how do you assess and where do you draw a line? So I don't know if you guys have a thought on what are the cohorts of patients and how do you assess the potential and how do you push the limits to explant, especially in ischemic, I say this acoronary syndrome, you barely see twigs of arteries that are there. So where do you draw the line in the coronary syndrome population?
I think that's tough, Arvind, and I agree with you. We just explanted a guy who actually is randomly his best friend is somebody who got a heart transplant in our program too. I'm like, you guys got to not hang out with each other. But anyway, so they both had acute MIs, and this guy, late presenting MI, in shock, ended up going right to VAD. And we explanted him a couple weeks ago. He had great hemodynamics. He had, this is something where you could use PET imaging. You can't use MR, right? It's a cardiac MRI because of the VAD. So using some sort of viability assessment, we're just, sort of thickening on echo, hemodynamics. But at the end of the day, if someone is, he was really pushing for it too. And I would say also the ability to tolerate high-dose GDMT, because GDMT is protective. This isn't, if you're on high-dose GDMT, you don't need a life vest. That's protective. So that's my thought process, but it's a tough one.
I had one last question. We're lucky because Alex, I think you did the first 5.5 in the world, and Jane, you guys did the first BTR. Where do you think the BTR is going to fit in this?
So I think, well, you go ahead.
No, you do the BTR
All right,
pump, so.
Perfect. Look at us getting along. So I think BTR is really attractive, right? For every patient for NIRS patient who doesn't want to get the durable LVAD because they're never going to get a transplant, and it may reduce their likelihood of, it's probably easier to convince your surgeon to take out the temporary impella than it is to do a full sternotomy or a thoracotomy and decommission the VAD. So I think it lowers the stakes a bit for if the patient needs something else down the road, if the impella needs to go back in or they need a transplant, it just gives us options. And so I think I see BTR fitting in for instead of restage with the durable VAD. BTR is right there. When we have better meds, we have ARNI, we have SGLT2, and we have good long-term outcomes. So that's where I see BTR.
I would fully agree here. So, I showed you the data. We really wait long for heart transplantation, so it gives us the options to wait for recovery. We don't often know when recovery occurs. We try to optimize patients in terms of kidney function and organ function infection before we explant the devices. So this gives us option. We can hopefully discharge these patients. And at the very end, if recovery does not occur, but we have more time, then we can go for any kind of heart replacement therapy.
That's a win.
That's a win for probably everybody here.
So we are finally back to bridge to decision and ending the agreement 2 session, I think. Thank you very much for your contribution.
Thank you.